Howdy, y'all. I'm Dr. Jeff Jarvis, and I'm back with another PIM. This one is a follow-up to the discussion we had about performance measures with stroke. A little background on stroke. As y'all know, there are two broad categories, hemorrhagic and ischemic. Hemorrhagic strokes are the minority, and they make up maybe 15% at most of all strokes. Hemorrhagic strokes are described based on where the bleeding occurs in the brain. Those on the surface of the brain are subarachnoid hemorrhages, and those inside the brain are intercerebral hemorrhage, or ICH. These typically are associated with a sudden onset of severe headache. The pain comes on at maximal intensity all at once over a period of just a few seconds to maybe a minute or two. Now, when severe, they can be associated with altered mental status. If your patient has an acute loss of consciousness associated with severe headache, you got to be thinking hemorrhagic stroke. As it turns out, most non-hemorrhagic strokes are not associated with the loss of consciousness or not associated with confusion. Most, but not all. And that's a general thing. If the patient you think is having a stroke is newly altered, acute decrease in mental status, think hemorrhagic. All right, so these hemorrhagic strokes, they're typically treated surgically, and they can do clipping of the leaking artery, and they do that endovascularly, or they can go old school, take a piece of the skull off. That's called a craniotomy, and they do that to release built-up pressure. Or maybe they just treat them with observation, depending on the severity of the stroke. Now, the most common type of stroke, those are ischemic strokes, and those are more than about 85% of all stroke. These are caused by blood clots that occlude the arteries in the brain, much like a heart attack, but in the brain instead of the heart. Now, there are basically two descriptions of clots based on where the clot came from. Those that are formed at the site of the occlusion, those are called thrombotic. This is the typical mechanism for the occlusion in an MI. Now, the other is an embolic stroke. That's where a blood clot forms somewhere else, maybe say in a quivering atria in a patient that's in atrial fibrillation, or in the clotted leg of a patient with a DVT or deep venous thrombosis. Now, these thrombi, because they formed in situ, on site, well, they break free from where they originate, and they travel downstream into the brain until they block off blood flow to a smaller artery. That is the embolic part. You have a thrombus that creates in one place, then breaks free, goes downstream. That's embolic. Now, ischemic strokes typically present with classic symptoms, the classic thing we think about as a stroke. Unilateral paralysis or weakness, maybe facial droop on one side, or difficulty speaking. Now, if it is facial droop alone, here is a little added pearl. How do you tell the difference between facial droop that is from a stroke or facial droop that is from something like, Bell's palsy or Bell palsy? Well, you look at the upper part of the forehead. Now, you would think that if the entire face is paralyzed, that's got to be worse. But it turns out that is not the case. If you have what is called a peripheral nerve lesion, so Bell palsy, your entire face is paralyzed on one side. That's because of damage to the nerve or inflammation of the nerve where it comes out of the skull. Turns out that is not a stroke. But if you have a facial droop and you are able to, say, raise your eyebrows, wrinkle your brow, that's much more concerning for a stroke. All right, so the symptoms that are present depend on what part of the brain the blood clot is blocking off. If it's blocking the part of the brain responsible for, say, word formation and speech, the symptoms are going to be difficulty speaking. Likewise, if it takes out the part of your brain, the left prefrontal cortex on, say, the left side, that's what controls arm motion, leg motion, you're going to see weakness on the contralateral or other side. All right, now, ischemic strokes, those can be treated with clot-busting drugs like TPA that break up the clot, but those drugs are only effective if given early, say in under 3 hours, 3.5 at the outset. Now, if they're given after that time, they're less likely to be effective, and they're more likely to cause bleeding that can convert that ischemic stroke into a much worse hemorrhagic one. That's bad. We try not to do bad things. So the best way to avoid that bleeding complication is to know exactly when the symptoms begin. And that is why it is so important that we document a last known well time in our chart. Now, larger strokes involving bigger arteries, those can be sometimes treated with thrombectomy or endovascular therapy. Basically, they go up into the artery in your brain with a wire and they break up that clot. It's just absolutely amazing that they can do this. It's basically like the PCR or PCI you get for a heart attack, but in your brain. And the one thing that I will tell you is that the arteries up there, they're a little more tricky to get to than the arteries in the heart. Now, I hear a stampeding chorus of cardiologists just dying to argue with me about that, but I'm just way impressed that you can do that in the brain. Now, thrombectomy, one of the added benefits of it is it can be performed out to 24 hours, but it can only be done at specialized centers. Now, getting these patients with large strokes, we call those large vessel occlusions or LVOs. Those getting them to the specialized centers directly, bypassing the centers that cannot do that, that can be the difference between them being eligible for treatment or not being eligible. All right, so I hope that information on the pathophysiology of stroke was helpful. I really think it's important to understand why we're doing what we do. And most importantly, I hope it is useful to help you understand why what you do matters and what you document matters. Well, guys, I feel really confident that not only can we blow this measure out of the water, we can do it in a meaningful way that makes a difference in patients. We already provide outstanding care to our patients. We need to be able to prove it. These measures, they really make a difference in people's lives, and they're going to be able to show our benefit. That's what I have for you. I hope this helps. Remember to watch the video on documentation of stroke scales. Thanks a lot, guys, and y'all have a great day.